Well, here's an SOS. Your patients who are on statin may need a little extra help, and maybe we have an idea as to how that can happen. We're talking about the Statin Outreach Support Study, and I'm with PharmD, Richard Lowrie, Glasgow, and a Young Investigator Award nominee. In fact, I saw an award over there, did I not?
Thanks, you did, Rick. Thank you.
Congratulations. And also, I want to talk first about the HOOPS trial, because you also conducted that in heart failure patients.
Yes.
So before we get to your SOS, let's shoot some hoops. What was that trial about?
Sure, that was a trial that was conducted 2 years ago, and we identified patients in primary care who had left ventricular systolic dysfunction. So we recruited 2,164 patients, and we followed them up on average over 6 years. And in the HOOPS we found that the pharmacists, while they were effective in relation to speaking to the patients and changing some of their heart failure medicines, the primary outcome, which was a composite of heart failure, hospitalisations and death, wasn't achieved. So, and nor were any of the other clinical endpoints. So pharmacists, we found from that, when they interacted with patients on a one-to-one medication review, were able to change the medicines, but didn't achieve the primary outcome of our study.
So now this time you're looking at statins, correct?
Yeah. This time it's a bit different. We have changed the tact and we've involved pharmacists collaborating better with general practitioners and practice nurses. And we have an intervention which is targeted at nurses and doctors rather than targeted at the patient. And the educational support we gave to the nurses and doctors and the organisational support meant that we were able to increase the prescribing of statins for those patients who didn't have any previously, and increase the doses for those who had suboptimal doses. And we also were able to, as a result of that, control cholesterol and reduce cholesterol levels, which meant that the patients who had been started on statins or started in new doses through the doctor or nurse, not by the pharmacist's direct impact, these patients who had been started on their medicines had taken them, and that had led to a reduced cholesterol level, which is good because the patient group we targeted are at the highest risk of suffering a clinical event. That is those patients with confirmed atherosclerosis.
So what was the message you were trying to target? How did you go about educating the physicians and the nurses?
Yeah, I mean, the main message was that patients who are eligible, that is patients who have confirmed vascular disease, should be offered simvastatin of 40 milligram per day for life. That's certainly what all the evidence says should happen. Of course, some patients refuse, but I think it's incumbent upon us to offer patients this treatment, at least. So that was the message we conveyed. We conveyed the message through the pharmacist being based in the doctor's surgery for up to a year, 1 day per week for a year. And during that day per week, they provided educational support and they helped the practice to organise their systems in order that they invited patients and they followed patients up if they hadn't come down to the practice.
So were you surprised to find a number of patients who had cardiovascular disease clearly and yet still weren't on a statin?
Well, not necessarily, because the evidence suggests that there's still a lot of room for improvement, and it varies, but across Europe, in the EuroAspire studies, across North America, and the LTAP study and the REACH investigators also in America have shown, and the message is pretty consistent, that about 40 to 50% of patients who should be on these things aren't on them. Now, while the reasons for that are multiple and complex, it's important to try and offer patients these medicines, and that I guess is what we did systematically for all the patients in the practices in the active group of this cluster randomised controlled trial. And we found that we could increase the uptake of this intervention, certainly. We increased the prescribing of simvastatin 40 milligrams to about 70-80% in the intervention group, and it remained about 60 or 70% in the control group who were exposed to usual care. The cholesterol control and intervention group, which started off relatively poor, then increased to 69.5% of patients who were involved, and in the control group the cholesterol control proportion of patients with cholesterol control was about 63%. So not too much of a difference, but it was still clinically, statistically significant. But the biggest change, as I mentioned, happened to the simvastatin 40 milligram prescribing, which, if you read the evidence base, is sufficient on its own to translate into changes in clinical events. So that was quite pleasing.
So the clinical message is just to remember, if you've got a patient with cardiovascular disease, try and make sure they're...
Well, absolutely, but I think it's a bit more than that. It's about the patients who have been asked but who don't return. And certainly in the UK, you have to persistently follow up patients who maybe don't understand the message. You have to get in touch with them to keep on trying to get them on these things rather than sending one letter and then forgetting about it.
The effort, clearly, is worth it.
Well, the effort is worth it in terms of the endpoints being achieved, but whether an economic analysis would show that the whole effort over that period of time costs less than the impact of the intervention en masse with patients remains to be seen. So I guess that's my plug for the next study we're now involved in, which is an economic analysis of the whole intervention from start to finish.